All right, everybody, we're gonna go ahead and get going. Welcome to the first Turtle Club of the year. This is very exciting. Today, presenting first, we've got Dr. Cheng, who in addition to being board certified in occupational medicine, is also a just fiction
Medicine. Yep.
Sure. Perfect. And so she's going to be presenting about something related to that. So she'll be great. I'm going to hand it over to Melissa. Where'd you go?
Thanks. All right. So for today's presentation, I got to use that doesn't work. Is it working?
Yeah, it's working.
Okay, we're going to talk about driving performance in cannabis user perception safety, a randomized clinical trial. This was published in 2022 by JAMA Psychiatry. All right. So cannabis in the US today. This slide was created in 2024 and a lot has it. These are, so as you can see, most states have some shade of, right? What is legal in Utah? Do you guys know?
Medical.
Medical. That's right. How many medical conditions are approved and recognized? Yes.
0,
5,
12,
47,
10,
17.
17.
How many of those 17 conditions do you think are backed by evidence?
0.
Very little. That's right. That's right. So, little background. I want you to know that in 1986, the endocannabinoid system was first discovered. So we've only known about the endocannabinoid system, which is where cannabis finds into recently, right? In fact, I'm way older than when this was discovered. And so what we know is that in the endocannabinoid receptor, you have these cannabinoids, and it's all over the brain, which really makes sense. When you think of acute intoxication with THC delta 9, which is the psychoactive substance, we see that when you're acutely intoxicated, it can impair memory because there's endocannabinoid receptors in the hippocampus, right? It's in the cerebellum, so your coordination is a little bit off. In the prefrontal cortex, your judgment is impaired. It's everywhere. All right. So keep that in mind when people talk about being intoxicated with cannabis and THC. Okay. So the purpose of this study had 4 aims. One is to determine the magnitude and time course of the effects of smoking cannabis. Determine the effects of cannabis with different THC amounts. 3rd, possible tolerance effects. And 4, accuracy of self-perception of impairment. Lastly, what type of study is this? Let's see how many of you guys are paying attention to the slide. Randomized control.
Wow.
Yeah, there you go. Did anyone get like special brownies already? Impairment and impaired. So what they did was they recruited people in San Diego, and they were looking for people aged 21 to 55 years old who currently use cannabis at least 4 times a month. Okay, they need to hold a driver's license and drive at least 1,000 miles a year. And they have to be able to abstain from using any cannabis 2 days before their testing day. Okay. The exclusion criteria was that you could not have like cardiovascular, like major cardiovascular disease, kidney disease, liver disease, acute psychiatric conditions like schizophrenia, and presence of THC on the day that you test will exclude you. Any questions on that? On why they designed the way they did? Okay, so here was the same study. It's a double-blinded, placebo-controlled, parallel clinical trial where participants were randomized to smoke cannabis cigarettes. And there were 3 types: placebo, 5.9% THC, or 13.4% THC. All right. you had to arrive cannabis-free and do a 25-minute driving simulation. And so they would do an oral testing and blood testing, make sure that you were completely free of THC. You do a driving test. This is your pre-test, right? Your pre-cannabis test. So when you are cannabis-free or quote unquote sober, you do this driving simulation. And this driving simulation was 25 minutes long. It was like 3 panels, and would go through like you're driving in the city, you're driving in the countryside, mimic a lot of like common traffic scenarios. And then you got to get high. So what they would do is they hand you a cigarette, okay? And they would say, you can smoke it how you normally would. All right, so if you're a little puffer, if you're like in the cartoons, you could take one big breath and all the cigarette just kind of incinerates in the first straw. It's up to you. You smoke till in a way that you're used to getting high. All right, the limit was you had to finish the cigarette in 10 minutes and you needed at least 4 puffs, okay? And then they would ask you in 30, 90, 3.5, 4.5 intervals. So 4 time intervals. How high are you? How impaired are you to drive? Would you drive in your current state? And then you do a driving simulation, the same 25-minute driving, okay? And then they also collect the blood and then the statistics with a Poisson and logistic regression model for discrete and binary. That's the type of statistics that they use. So here's what happened. 199 people were randomized to the 3-arm, okay? Placebo, the 5.9 and the 13.4. However, 8 people failed, 6 showed up, tested positive the day out. They couldn't stay sober, right? And 1 left after smoking pot. So they may have gotten a little like paranoid and was like, I can't do this, and then left. So out of the 191, there was 118 men, so roughly 62%, right? Average age was 20, almost 30 years old. Average cannabis use in a month was 4 days, 16.7. And then they usually smoked roughly 1 cigarette. And here is table 1 of the demographics split into the 3 groups. They're roughly, none of it is, if you look at the p-value, all right, they're all roughly the same. So what do you think the results were, guys? So I want you to know that for the driving test, higher the number, worse the drive. Okay, so it was a change. So these values are a change. So if they also went from 2.6, that's a change, meaning a worsening of their driving. So they smoked pot, and at 30 minutes, the placebo was roughly the same, right? Or maybe they got a little bit better because they drove the first time, and so they know what to expect off what the videos show. Well, the people who smoked THC, they were worse at 30 minutes. At the hour and a half, placebo, still the same, maybe a little bit better. And with smoke pot, they were worse. Okay, 3.5, starting to trend towards 0, and they were not, there was no statistically significant change in the way they drove until 4.5 hours. So after smoking pot, they needed at least 4.5 hours to reach back to the same driving capability. Does that make sense? Does that make sense? And so here it is on the more numerical way. And so as you can see, at the 30-minute and the 1.5 hour, it's statistically significant that there was a definite worsening in their driving at that interval. But what you'll find is there was no difference in how they drove between the 5.9% THC consumers and the 13.4. So because there was no difference on the amount of pot that they smoked, they pooled it together, okay? So the conclusion of the study found that THC concentration of 5.9 or 13.4 did not impact driving impairment. So the person who smoked 13.4 wasn't a worse driver than the 5.9. The greatest risk for impaired driving was the first few hours after use. Does that make sense? Yeah. And then at 4.5 hours, driving was no longer statistically significantly worse than pre-cannabis. But what's really concerning that I want to highlight is this lack of insight regarding driving impairment. All right. And that there's this inter-individual variability seen with the impairing effects of cannabis. And what that means is you would assume that the people with 13.4 would be worse than the 5.9. Is there a different way that they're smoking it? Right? And or is there a different tolerance? Now, I want to go back to this because I forgot to talk about this slide right here. That is the most troublesome. Is these dots is their perceived sense of impairment. And you see at 30, roughly half felt that they could drive. They were like, yeah, good. I'm not that high. I can drive. But they were really crappy drivers. Okay. And at 1.5, about 70% felt that they could drive. But they're really crappy drivers. Okay. And then it wasn't, and then at 99%, they felt that they could drive at 3.5 hours. And then everyone felt that they could drive at 4.5. And it's that they can't, right? But this section right here, the impairment that they thought that they were okay is really fast. Okay. So strength of the study, it's a unique study, right? It's a large sample size. So in fact, when you look at any of the cannabis data that's coming out, a sample size of 200 is a really large study. Most of the stuff out there is like 20, 30, maybe 40 people tops. And when people start saying, oh, study shows that it helps with chronic pain, those studies have like an N of like 20. Okay. And we can talk about all the different studies out there. It's actually quite scary, especially when you take your epidemiology class and you're starting to understand like methods section, and you're going to be like, wow, the methods don't even make sense what you're trying to explore. It's a validated screening driving simulation that they're using and closely monitored THC dose, quality of the THC. And what it shows is that the topography, how someone uses in this is a little bit interesting and making more research, right? Like how you inhale, how deeply you inhale. Are you someone that I don't inhale and just kind of put it next to your lips? Or are you someone that really leans into it, right? But then this is smoking. How would this change for people who use edibles or gummies, right? Weakness, so you cannot generalize naive, infrequent cannabis user, older adult or user, okay, and people with medical comorbidity. Because remember, the exclusion criteria was for people who had major like internal organ deficiencies. You can't generalize about other methods of consumption. You cannot comment on the performance over longer driving periods. So what would your driving be if you were driving cross country across the plains of Wyoming and Kansas where there's like nothing, right? And you're in proximity. Are you going to be spurting more? Are you going to be falling asleep? Who's to say? Okay. So what do you guys think of the study? And it sounds like the study was not given. None of you guys read it. Okay. Usually what happens is journal club. They will email you a copy of the paper and then you guys will have read it so we can have a really robust discussion.
They got email copies. We just didn't get this
How
one.
many of you guys read it? Thank you. Thank you. Let's have that robust discussion. And you guys get a gold star from me. Okay. Do you think that they met their aim? Think of what the first 4 aims they're studying. So to go back, aims of the study is to determine the magnitude and time course of the effect of smoking cannabis, determine the effects of cannabis within different THC amounts, possible tolerance effects, and for accuracy of self-perception impairment. Do you think they met that?
I have a comment. Their method of dosing had a lot of generalizability, but it was low in its control for exposure dose. So letting people smoke how they normally do has generality to normal practices, and same with the task, but they could have chosen a different path of a more precise dosing so that everybody had the same blood concentration of THC.
And what I didn't show you was that they did show like the blood levels of it, and that was all higher. So if you were in the arm of not the placebo, one of the treatment arms, your blood concentration of THC did go up. So you did get some form of THC. Back to you.
In your professional experience, not your personal experience, was that the amount they got? Was that just like a regular that high session, or was it just one cigarette? I can't remember what you said.
It was one cigarette, and it had different potency.
Yeah, but so is that what normally people would use, or would they be using several cigarettes over a period of time? You know,
So,
they were-
so it is typically used with the one cigarette, and then the dose of 13.4 we're finding of our permit because of the type of cannabis that's available. It's much more potent. It's not the pot of my youth of the 80s and 90s, right? It's much more potent, and people are vaping and dabbing more than they're smoking flower. And dabbing, which is a type of wax you get melt and you inhale the fumes, that has a very big THC content. Where dabs are typically like 90% THC, 90% THC, so a lot more potent. And then vaping, I don't know if vaping is really people out right now. And it has close to 20% THC content. So it's really potent.
The fact that concentration didn't affect like how impaired their driving was is interesting to me. In the blood concentration levels, was there a difference in like the blood concentration given what?
Yeah.
Okay.
So there was, but there was this individual variability that we saw, right? That you would have the person smoking 13.4% and inhaling very deeply and getting more of the amount that has a higher THC blood content would have poorer driving, and we just didn't see that.
Interesting.
Does the study talk at all about how those who would have gotten the placebo probably knew that it was a placebo the moment they didn't get high?
They didn't talk about that. That could be, and what's it called?
Like just their bias, or I guess figuring out what part of the blind that they're in. I don't know exactly what.
I know there's been other studies with alcohol along those lines, where they brought people in to do like a wine taste test or something, and then it's not alcoholic at all, but they do start acting drunk after having a couple of glasses. So it could be like that as well, where they're just assuming they're gonna get a hit, so they behave accordingly.
Yeah, there's a range of conditioning and learning effects present in drug studies. There's state dependent learning, so you can learn things under the influence that you actually are better at when you repeat them under the influence. The repeated driving simulation, there's a potential for getting better at it with each repetition.
Yeah.
So one question I had was, to what degree did the simulation change with each repetition? And then there's conditioned drug effects, so exposure to the smell of or to the experience of things to do with the intake of drugs have their own effects, and also the place. So conditioning and learning is theme to dig into with these sorts of drug studies. And while I've got the mic, I'll just say about a third of the distribution of drug exposed participants improved in their performance. On average, they were worse, and it's all concerning. But that very interperson variability is super interesting, and I'm sure the researchers are digging into the blood levels and trying to explain, that variability.
So have there been studies, or what is your professional conclusion about different intoxicants, someone drinking versus someone taking THC. How different or similar are their self-perceived impairments? So how do they are people under alcohol better or worse able to perceive their own impairment?
I don't know the literature on substance, right? But we know that alcohol clears faster because alcohol metabolizes. For my medicine people, which kinetic order does alcohol get metabolized?
First,
No, zero. Zero kinetic order. And then cannabis is more of a first. Okay. So what that means is zero kinetic order is an absolute amount gets metabolized every hour. First degree is a percentage gets reduced every hour. Okay, so it's going to take longer. And THC is also fat soluble. Okay, so it can store in your system a bit longer. So we know that your metabolism for THC is slower than alcohol. But what is really interesting is the perceived sense of impairment when you take naive versus frequent substance, whether it's alcohol or cannabis. If someone rarely uses it, their perception of impairment is more conservative. Oh, I can't do that, right? Like people who never smoke pot, they're like, oh, I'm never gonna do that. But someone who is a habitual alcohol or cannabis or whatever it is, their sense of tolerance and ability to perform is that more less conservative, more permissive, I should say, right? And whether it's real or not. I think the study does highlight that even though these people normally smoke a lot of marijuana, right, more days than not, that even though they were using a substance at the amount that is typical, right, they still had an impairment all the way up to 3.5 hours, even though the majority, or at least half of them, felt that they could drive at 1.5 hours.
The lack of insight regarding impairment applies to sleep deprivation. So I think it's in general kind of a human characteristic that we're not the greatest at detecting our level of impairment.
Yeah, no, that's true.
One of their aims was to like look at tolerance and stuff, and yet they didn't have them sort of a consistent amount. Like they said, you should do a minimum of like 4 puffs instead of like finishing the cigarette. So why would they not control it?
It was the perception of normally being high, right? So if you normally, so we didn't want to like, I think they did it so you wouldn't overindulge if you normally only did 4 puffs. So it was up to your sense of, I will smoke to my comfort, not a designated. All right. What do you think about how they pooled the results for 5.9 to 13.4? Think that was appropriate in their analysis? Yeah.
I think it's appropriate because they didn't control for dosage, and so everyone kind of stopped when they were like, oh, I'm high, rather than at a certain.
Right. And that's exactly right, right? Like the people at 13.4, did they just maybe did 4 puffs, and everyone who did 5.9 did like 10 puffs, right? And then there wasn't a measure of like their cigarettes went from 3 inches down to 2 inches or any type of like control for that. Yeah. Because the outline was their goal was smoked until you get high. So if they had a more concentrated cigarette, maybe they inhaled less, but that wasn't discussed.
I apologize, I did not read this, and so I'm just curious, did they talk about the reason why they did it the way that they did it, particularly in terms of generalizability? Were they actually trying to, were they trying to create generalizability by not being specific in their dosage and that process? Or was that just kind of a, oh, I guess we did it that way, so I guess it is generalizable? Does that make sense?
With an intent that they were
They were
saying
intending to do it that way.
that you smoke at a level that you would
Yeah.
normally smoke.
Okay. So allowing for a better generalizability to if they were at home and they smoked and then they had to go get some milk at the grocery store,
Right.
you know, what would be
You
their
smoke
level?
normally and now I have cravings and right, can I go get them, or do I need a door? And the answer is.
Yeah.
This is like marginal, but like with alcohol, if you wanted to control for like level of drunkenness, I'd imagine you could do something like number of shots, body weight, and like maybe how frequently. And were you saying like with the individual variability that does not apply to marijuana, like,
I wouldn't say it doesn't apply. I would never make these like broad statements, but in this study, that it didn't necessarily.
So do you think the concentration levels were too close together? You brought up how, you know, they might have like upwards of like 30% of THC, so why wouldn't they try and match maybe what is available for like these people in their daily lives?
I don't know if it pass IRB. Right? I mean, Kurt, what do you think? If you were to write an IRB study for this and you wanted to get someone super stoned and have them smoke 90% dabs, but remember, especially, you know, they may be, they're not opioid, I mean, they're not cannabis naive, but if you got them super lit, there are side effects, including like heart attack, stroke, acute psychosis. You all of a sudden, you know, sprung on their schizophrenia, right? And these are all legit side effects that we see from too much cannabis. So it's not benign. And so there will probably be a little bit more.
Fair, yeah.
Right. So, yes.
This is great, thank you. Just to mention a couple of things, because people may not know. Do you want to comment on the potency of today versus the 1970s?
Not even 1970s, even the 1990s, like my pot, right? Like, the-
Practically speaking.
no, you guys should know. I did. I did it in my youth. And that was it. Right? And so there's some lived experience, right? But the cannabis now is not the cannabis in the price thing. And a lot of people have that misconception, especially when it comes to like, oh my goodness, because I smoke pot. Well, the pot is not the same. It has all been genetically engineered to adapt. Not only is it more potent, higher THC, it's now at a ratio of a THC to CBD. So everyone knows about this. Oh, CBD is like panacea, it saves everything, it cures everything, right? There's no that. But we do know that CBD is a little bit more benign than THC because it's not psychoactive. It doesn't cause the hallucination. It doesn't cause the paranoia. It doesn't cause any of that acute psychosis that would lead you to. And so what happens is, what we find is CBD is a competitive binder to THC. So you have an endocannabinoid receptor. And it used to be like a 1-to-1 ratio. So THC would sit on the receptor. It would kind of be neuroactivating. CBD would come in, kick it off, right? Well, now you're seeing formulas that's 10-to-1, 5, like 10-to-1, 20-to-1. So much more psychoactive. So a lot more neurostimulating to the point that I would say neurotoxic. And there's no CBD to kick it off. All right. And so you see this 10-fold, 20-fold increased risk of schizophrenia after habitual cannabis use. It's very aggravating. So it's not benign and it's not the same population.
would you say the potency of like, if I were to have 10 milligrams of THC and 10 milligrams of CBD concurrently, like that potency is less than if I were to just have 10 milligrams of THC and no CBD, even though the psychoactive component is the same?
I don't know. I haven't seen studies for that. This is new growth, right? And there just hasn't been that type of evidence out there.
Thank you, that was really good. Just so people know that ACOM has a cannabis guideline coming out imminently. It was really surprising what we all found with the data, mirroring much of what you said. In Colorado, there's more than doubling risk of fatal car crash. It was 85% increased risk of injuries. And everybody in here is going to be dealing with this one way or the other, unfortunately. If you go skiing at Brighton, you'll surely go through a cloud. Apparently our 18-year-olds with medical marijuana left and right. So, but this is looking very much like the opioid epidemic, plus the tobacco epidemic, plus a new one, which is schizophrenia, all combined into the onset of a new massive epidemic. So we've set off in Cheney. And I didn't think we were gonna end up there with this guideline when we started down that road, because I was like, oh, we'll find, interesting stuff. Well, we found very interesting stuff in a not good way.
So my last question for you guys. You guys are the safety manager for another time, right? In a state with legal recreational marijuana law. What do you do?
How is that? And, okay, I don't know that much about this, but how is people smoking marijuana on a break any different from smoking like nicotine, like a cigarette?
So,
Yes.
so,
Peppermint versus
Oh,
no.
there.
right, so when you have acute nicotine exposure, you're acutely intoxicated. What are the side effects and symptoms of acute intoxication? Anyone? No, it's a legitimate question. This is a safe space. This is the time for you to answer that. I don't need you to go like experiment because you're afraid to ask. Right? So acute intoxication with nicotine, maybe your heart rate goes up, right? Maybe you're a little bit more alert, but you're mildly stimulated, but no psychosis, no visual impairment. Okay. Acute intoxication with cannabis can cause a lot of things, and it's dose dependent. And the issue is no one has a dose. When people say they're going to use it as a medicine, when you take ibuprofen, you're going to take 200, or you're going to take 400, or you're going to take 800 milligrams, right? With cannabis, what do? Take a dab, take a hit, take a gummy, take a quarter, right? Like, how do you dose that? But what we do know that in that dose dependence, it can range from acute sedation, which a lot of people say I need it for sleep, which is as effective as a shot of whiskey, by the way. Okay. So it can be sedating, or it can be very active, meaning you're seeing distortions, you're visually hallucinating, you have active paranoia. Yes, people are staring at you. Yes, I'm really hungry, right? I make you. Do you want someone who have active neurostimulation, with paranoia, with depth perception, with coordination issue, working in an older refinery or driving a large vehicle, or even driving behind a wheel, right? So those are the real. But what troubles me is that we've moved away of public health education on the dangers of cannabis, that a lot of people don't even understand that there are side effects and risks to cannabis. There's a study that says 30% of American population believe that there are no side effects to cannabis, like none. Like, how are Cheech and Chong videos so well known if cannabis had no side effects, right? It's two stupid people, it would just be Dumb and Dumber. But the reason why Cheech and Chong had videos that was different from Dumb and Dumber is because they were all high, right? So we know. And then there's other effects like amotivation. And there was a great study that followed a cohort of kids born in 1976 in New Zealand, about 1,000 of them, and they followed them for 40 years. And they were able to differentiate kids who started, especially teenagers who started smoking marijuana at a really high rate. And they continued and maintained that when they were 36 years old, their life quality was very different from people who maybe did it recreationally or not at all. I mean, significant marital, familial income. Their lives were very different. So back to the question. You guys are the safety manager. What are you guys going to do? Because this is going to be a real scenario. Yeah. What are you going to do about that question?
So my experience this summer, I worked at a mine power plant in Montana,
Yes.
and they do not allow employees at all to smoke marijuana. So they do randomized drug testing periodically, or if they think that you are smoking marijuana, you get drug tested. And the fact is that they're year-round machinery and equipment that can cause explosions, cause serious damage, death in the meantime, as well as many other things. So as a plant manager or safety manager, you have to enforce that. and not even allowed on the job site, in my opinion. Because there's so many different hazards in situations like that.
You wouldn't allow someone to carry a flask
No.
on job, that little martini lunch, right? I'd say.
Like, they even have rules to where you have to not consume alcohol 12 hours before you even start a shift. They do not want that at all.
Right. Anyone else? Yes.
I think based on the results of this study, something that would be important is doing like a training on knowing how actually impaired you are. Because the discrepancy between perceived impairment and real impairment was large in the study, so.
Absolutely.
Because there is a public perception that is very different than reality, I think as safety managers, one of their first things they're gonna have to do is educate. Because they are absolutely, they have people in their organization right now who believe that there is no side effects or impairments or anything like this. It's a miracle drug. It saves everybody, right? They have people that believe that because it's been spouted and said by people that they trust, right? And so they have to, have to teach that. They have to get the ACOM guidelines that are coming out. They've got to get studies like this. They've got to teach that because we have to change the public perception or at least the at-work perception. So that way they don't, inadvertently impair themselves and then blow something up.
Any other questions, comments?
Having been in the oil industry most of my career, I can tell you that most of them are now allowing marijuana unless you're in a regulated program like pipeline or FMCSA, something like that. Then as long as, you're not allowed to use it, but then you're coming to work, but it's too hard to enforce. So essentially, they're taking.
This is a very nebulous field, and it's rich for discussion, right? Because there's actually studies out there that protect people and allow for cannabis, like Nevada. Nevada explicitly says we cannot buy against someone who uses cannabis, regardless of being sensitive. So do you want your neurosurgeon who's going to be operating on your brain being a big, big joker? Right? Something to consider. Yeah.
Down that line, like, I would feel as uncomfortable with that as a neurosurgeon who drinks a lot, and there's a huge prevalence of like drinking. I guess it's just like, it's what I know, isn't it hard to test for like you can't do a breathalyzer for marijuana?
Yes.
Maybe that's different, but.
You're right. So testing acute inebriation for cannabis is hard, right? Because you have the oral swabs. Okay, so you have the blood test, you have the urine test, but that doesn't necessarily correlate with acute impairment. And what people are using now is an oral swab. And some of them can be as sensitive as determining if you've had something in the last 3 days, if you're an infrequent, assuming like you're an infrequent cannabis user, right? That the saliva can tell if you had. So that we don't know if it was 3 days and you're on vacation. 3 days ago, you're just coming back onto the work site. So there's a lot of issues with testing. And the best way to test is like function, right? It's like a driving simulation test. But no one is really doing that. There's really no economic way of doing it. I mean, in a perfect world, I would love everyone to have a big driving simulation. And it says, okay, I can do it. But if you're impaired because of sleep, because you're hungover from partying from alcohol, if you're currently intoxicated, if you have you're hypoglycemic, if you're a type 1 diabetic, it's not out of control, any type of reason, and you are not performing well under this, to have an evaluation. That I would love to see in a number. So. All right, any other questions? Thank you for allowing me to be the first. So I set the bar low for you guys. You guys are all going to be awesome.
I'm gonna struggle to follow that up because we're not talking about anything nearly marijuana.
Wore my green shirt for you guys.
Thank you. Right, before we dig in, I've got a couple housekeeping items regarding Journal Club this year. And this is relevant for everyone, but a couple different changes for returning students who participated in previous years. One thing that I'm going to be doing is I'm going to be timing presentations this year. The makeup of presentations are really meant to be like 15 minutes of slides and the presentation itself, and then 15 minutes of discussion. So what I'm going to do this year is I'm going to be at 14 minutes, I'm going to hold up an orange card. You'll see, okay, I've got 1 minute left. And at 15 minutes, I'm going to hold up a red card to let you know that you need to be shifting into the discussion portion rather than just going through slides. That's sort of the format, the discussion then, or the slides, then the discussion is the format that most people choose to use. That's not to say that you can't intersperse discussion throughout. And if you're planning to really heavily intersperse discussion throughout, let me know beforehand because the science thing may not be as workable for that format. And also, 15 minutes of discussion really puts the onus on you guys as presenters to formulate good discussion questions, engage people. Don't be afraid to, reach out to the audience and call on someone, even prep someone beforehand by calling them. But really be thoughtful about prepping the discussion portion. I thought this discussion from Dr. Chen's presentation was awesome. So I think that's a good bar for what we want to get into. Secondly, most of you or all of you should know that you can attend these virtually. If you do attend virtually, you have to have your camera on, all that stuff. That's not changing. This year, I'm going to do a better job of engaging virtual attendees to actually pick off their mics and verbalize questions and comments. So when you do attend virtually, know that you need to be actively participating. And if there's a lull in the conversation, I'm actually going to start calling on some people online to make sure that they're awake and not browsing the internet. They're actually paying attention. Lastly, something that I have not mentioned previously this year is we do require students to incorporate AI some way into their presentations. Last year, the way there were some really cool things that people did last year, but a lot of the time, most people would typically just generate an AI image, which was fine. We were just dipping our toes into AI last year. This year, we're going to push you to go a little bit further and actually use AI to analyze the article, to compare something, or digging a little bit more to AI. So you should have some AI components. Be creative, do whatever you want. So just get into it and explore. Any questions about all that stuff? That's a lot of info. Cool. All right, I'm going to.
One question.
Do you have any advice to students about selecting papers for discussion?
The thing that I always tell students, that's great because that's a common question, is figure out, you guys are all doing theses or dissertations or have lines of research that you're interested in. And it's a great way to gain knowledge and dig into it by finding an article that is something that you're either going to cite in your research or that you're interested in. You can talk with your advisor or program director, and they're going to lead you in the right direction. So that's sort of, I guess, the direction that I would typically go. But again, it doesn't have to be. You can go into your direction research with the papers that you choose. So I'm going to start out today with a confession that those of you who have heard me speak before know. I'm not a professional public speaker. So I'm talking about how to do this, but I'm not an expert myself. I don't get paid to do this. No one from TED Talk is coming knocking on my door asking me to do a TED Talk. Although if they do, I've got topics lined up, like sacrifice bunting in baseball, Bruce Springsteen, the abomination of Forrest Gump beating Pulp Fiction for Best Picture, which should say defies logic. So if anyone from TED Talk listening on Zoom, you know where to find me. Anyway, no doubt that there are some of you in this room who are much better at this than me. But what I do have is a background in communication. I've watched Journal Club now for 3 years and noticed some patterns of the things that students typically do really well and some of the things that they need to work on. So I'm going to dig into some of those things, and hopefully this will be useful, not only for Journal Club, but going forward for public speaking presentations as well. So this is some of the stuff that happens before you even open PowerPoint or actually dig into creating your presentation. The takeaway here is that being thoughtful and intentional as you prepare. In the early part of the process is going to pay really big dividends. Not only for your audience, because they're going to actually get a better product of your presentation, but it's actually going to make putting together your presentation a lot easier because you've got a roadmap of where you want to go and you're not trying to struggle through it as you go through. So I would really just encourage not skimping on the preparation elements of before you dig into the creating the slides. Any questions about these? Right. Shifting to the process of actually creating the presentation itself. This is an area where I sometimes see students struggle with this type of stuff. It's very rare that we have a student come up here who has not thoroughly read their article and doesn't, make a really good attempt to understand the research and isn't really fluent with the research. It's more of how they're presenting it. I see a lot of presentations that sort of struggle with presenting complicated information in a way that is not only digestible, understandable, but also really engages the audience. So, and getting a presentation and slides that look good is important. I'll talk about that a little bit more. By show of hands, how many of you guys have had the experience of being in an audience and seeing slides that are just like a wall of text where it's just like so much and you're like, I'm not even going to pay attention. I'm backing away. I'm done. Yeah, so I'm seeing head nods. I'm seeing hands raised. I'm guessing that most of us have had that experience. So it's really important when you're the presenter to make sure that that's not the experience that you're giving your audience. And I see this in Journal Club a ton, where it's just like wall-to-wall text on this thing, and you can't make head tell of it. And one of three things is going to happen, right? Either people are going to stop listening to you so they can read your text. They're going to not read your text that you presumably worked hard on putting together, and they're just going to listen to you. And number three, they may just zone out altogether. You'll be up here talking about like NIOSH, noise limits or whatever, and I'll be right there thinking about the 1995 Academy Awards and the atrocities that occurred there. So don't do that. Think of your slides as talking points that guide the conversation in the direction of your presentation, rather than something that you should be, reading word from word from, or as the main vehicle to convey the bulk of your information. Another thing that we see all the time in Journal Club is weird acronyms. We do that in academia. I understand that. We do that in research. I get it. They're everywhere. But for an audience that is not familiar with that acronym, it's really tough to follow along. And I think in Journal Club, we've gotten a little bit better at that over the last few years, and hopefully we'll continue to do so. If you must use an acronym, please define it early on in the presentation. And I also think it's a really good idea to throughout your presentation still verbalize the whole thing rather than vocally relying on the acronym, so that you can guide your audience along there as well. And lastly, obviously this is not a paper, but think of a PowerPoint presentation as a written product, like a paper is. You would never submit your thesis or dissertation to a committee or an article to a journal without editing it for grammar and clarity and really paying attention to that stuff. So having the same level of care with the PowerPoint presentation is really important as well. Beyond text, obviously the other component is visuals. And this can be tricky for Journal Club. There's not a ton of great images like particulate matter or carpal tunnel syndrome or things like that. So it can be sort of tricky. But humans are visual creatures. They're just the way that our brain works, that information paired with some visual stimuli is more beneficial than just text or just even vocal words. So it's something to really be thoughtful about. One of the big things that I see with this in Journal Club is big tables take up, again, take up the whole screen, or that the text is like really tiny, and even in the front row, you're sort of squinting to see what's going on. And so I don't have like a great solution for that, but maybe you can crop the table to just the information that you really want to focus on. Typically, we have printouts of the articles as well, so maybe you could say, hey, everyone refer to table 4 in the pamphlet. That might be a way to get around it as well. Even if you struggle to find good images that go along with your presentation, finding ways to add a little bit of visual polish and flourishes will go a long way toward engaging the audience. And it also just gives you added credibility when you're standing up here and making it clear that you put a lot of time, effort, thought, professionalism into the presentation. Any questions about any of that so far? How are we doing? Perfect. Yes.
Could you define the Goldilocks?
Absolutely. Yeah, the Goldilocks zone. this bullet and this bullet sort of aligned together. Again, getting back to the idea of you don't want to be reading word for word from your slide, and you don't want your slide to be doing the job of conveying all the information. So put as much text on here as you need, but not more than you need. So that's the Goldilocks, finding the middle amount where it does the job, but not too much. Okay, now you've got the draft of the presentation made. You're really proud of it, looks good, awesome. Next step, obviously, is to practice and rehearse and do those things. No one in Journal Club presumably is gonna be spending like 2 months rehearsing. I understand that. You're not gonna like stress test it with like 7, rehearsals in front of family and friends. Nonetheless, doing it, in front of the mirror, 1 or 2 times, or even finding someone in your life who you, feedback you trust to deliver it to. And they can, give you feedback and improve that way. It's really important. I think that's really beneficial even in Journal Club. And then when you do have a presentation that's a little more higher stakes than this, thesis defense, dissertation defense, presentation to a C-suite when you're in your careers, those types of things maybe do warrant, okay, I'm going to prep this for a month and rehearse it 30 times. And there's just nothing that improves a presentation than more than practice. Just getting up and doing it, getting comfortable with it. That's really the way to make sure that you're ready to go. And this is not as critical in Journal Club because the environment is controlled. We know, okay, here's the display size. We know the audio is gonna hopefully work well, not always, I guess, but most of the time. But we pretty much got that taken care of here. This is more important when you're delivering a presentation elsewhere where you're not as familiar with the environment. Is the display size tiny? Okay, I need to make my font size bigger. If I'm playing a video in my presentation, I need to have some idea that it's actually gonna play and work. Just, those unforeseen, problems, you want to be able to encounter them, address them beforehand. It'll, give you less stress and obviously reduce the risk of unforeseen problems. These are skills that you develop over time with a ton of practice. Like I said, I'm not that experienced in public speaking. I'm not that good and comfortable with it. It doesn't really come natural to me. But I try to be thoughtful about it. I try to follow some of these things. I try to practice, and over time, I think I've gotten better at it. I was a journalist before coming to Romco, and one thing that I did in that job was I was frequently asked to moderate candidate debates and public forums and things like that. First time I got asked to do it, I dreaded it. Like, it affected my sleep for a month. It was tough. But I prepped a lot. I did it. It went pretty well. So I kept doing it. I kept getting asked to do it and move forward. And eventually, over time, developed a level of comfort with it where it was actually fun to be on TV grilling these candidates outside. So if any of you have like really in-depth thoughts about Park City's zoning laws, let me know. We can facilitate a debate and it'll be fun. When you guys are in the audience, what things, beyond this stuff here, what things have you noticed that a presenter or a public speaker does really well to make you lean in, that engages you? What are some things that,
When it feels like they're having a conversation rather than reading a script.
Right.
I like it when they have a little bit of a sense of humor. So, every once in a while, there's just a little bit of a break in it. Like, not all the time. So not that being this focus, but, just so you can see kind of they're a person that connects with you.
yeah, not taking it so seriously and trying to,
I like it when they quote Forrest Gump.
Right. I like Forrest Gump. All I'm saying is that Pulp Fiction is like the most influential movie for my lifetime, and Forrest Gump is fun. Okay.
I haven't into that.
There you go.
I think it is important that they're consistent within their slides. And I've seen a lot of presentations here where they'll use mg here, use milligrams there, spell the whole thing out. Sometimes use a capital M for megagram. And, as a reader, you're trying to you don't want to have to keep shifting gears to follow the speaker.
Right.
So please be consistent in presentations. And for anyone in Ahmed, we're just simple, I'm a simple engineer. And sometimes I'm spending half the presentation Googling the acronyms that you've already mentioned.
Yeah, right. That gets back to the idea of knowing your audience and, in this room. And I'm going to, call out the mechanical engineering because you guys do that really well. Like, you guys understand, like maybe industrial hygienists are not going to know all this stuff about robotics. So that's one thing. at all of you guys when you guys present. That's really good.
So do I pay you now or after?
Hey, anytime Venmo, Cash App, whatever, we'll figure it out.
Okay, while I've been talking to you, I'll ask you a simple question. Is it a good idea or a bad idea to finish your presentation 5 minutes before journal club? And what are the consequences?
That's a very bad idea. The consequences will be, I will politely say you should have gotten it to me like the day before. And I will, you risk public humiliation by coming up here. So I don't know.
Bubba, one of the things though with confidence and something that will kill the audience's confidence in your presentation is filler words. And a lot of people use those and don't realize how much they use them. So I think it's really important to note that.
That's a great point. Yep. I think that goes back to rehearsing, because if you feel comfortable with the content, okay, here's what I'm going to say, here's generally how I'm going to say it, you're less likely to leave them afterwards. Right.
I'll add to that how you begin. Begin with a clear, purposeful story or hook. If you start with apologizing or sorry, I got this together at the last minute, I sent Bubba the slides 5. The way you start conveys a lot about your preparation and confidence. So if you prepare and rehearse that, especially the first entry point, you'll do well there.
Right, absolutely. Evan.
When it comes to discussion, don't be too afraid of silence. I've got a friend who's an excellent teacher and he will sit and wait a solid fiscal minute. And he's had people just break in the audience saying, please God, tell him. And maybe don't go to that extreme, but sitting in silence can be a useful tool to actually getting a conversation going.
It is.
Dr. Heckman.
I think there's 3 things that I view. This is a little bit beyond this narrow issue. Why are we doing this with our students? Well, number 1 is you and everybody needs to learn how to be better at presenting and communicating issues. That includes me. I'm definitely not mastered it, I'll tell you that. 2 is you will make more money. People can communicate ideas and put forth programs to intervene and reduce risks. You'll be successful, you'll be more successful. And 3, that success will be measurable in terms of reductions in injuries and diseases. So there's really at least 3 major reasons we want. I guess I should add a 4th, critical thought, not taught well. We want to show you how to think critically. So that's why we have so much fun on this journal club.
Yeah, and that's why when you're standing up here and presenting in journal club and a faculty member or a fellow student kind of pushes you on a question, it's not like, oh, they must know the answer to this or if they've done a bad job, because that's not, no one, here is an expert, at least the students. But be willing to engage, be willing to be asked questions that you don't know the answer to. Say, you know what, I don't know, here's what I think, but what do you?
You just started to say the thing that I say every time, every semester, beginning of the year about journal club. You're choosing an article that someone else wrote and a study that someone else did. Their mistakes or their good things you didn't do. So when a faculty or a peer says, why did they do that? That means this can't work for that. We're gonna critically evaluate these articles. We're gonna criticize them for the things that are limitations or problems or things that we see. They're not your problems, okay? So don't take offense when I say, well, this article is garbage. It's not your article.
Yeah.
Okay? You don't need to feel bad about it. The authors probably should, but you don't need to feel bad about it. In fact, you should feel good that you selected something that allows us to dialogue about what is good research and what is not very good research and how we are trying to do good research and help you identify that. So that way, when you're making decisions that are going to affect the well-being and welfare of people in their workplaces, you're making it based on good research and not based on garbage. So don't ever be offended when we ask a difficult question, point it back to the author, say, well, you know what? I don't know why they did that. What's wrong with it? It's okay to say those kinds of words because it's not your fault. Okay, so don't take offense when we're getting critical, because we will.
And one thing real quick, and this is something that helps the reader and the presenter, is unless you only have 5 slides, put slide numbers on your slide, because if I have a question on this weird chart and you have 20 slides, I can say, well, on slide number 12, you said, rather than saying the green figure, you know, at the top right or something. And as a speaker, you don't fumble trying to find that, you can stay a little more focused.
That's good. I'm gonna incorporate that next year. Good.
When choosing articles, pick something that you know or passionate about, right? It kind of helps finding a topic that you like and are not afraid to dive deep.
Fun. I mean, it's funner to it's work to put these together. It's funner if you're doing something that you're interested in.
I love cannabis, so.
That's the takeaway from today's session.
People on non-drug.
We're out of time here, so I'll just go through these really quickly. You know, just Q&A, finding ways to engage the audience and involve them. You know, some of the stuff we've talked about here is really important. This, you know, this is not easy for anyone. I don't think it comes naturally to very many people. So be okay with that. Just practice and dig in and do it and try it and you'll get better. Great. Any other final thoughts? We've had a good discussion, but anything else?
Why are you so upset with Pulp Fiction, Forrest Gump, When Shakespeare in Love, and
Saving Private Ryan.
and
Right. It's because two things. Number one, I think it's funnier because Forrest Gump actually is a pretty good movie and people love it, so I like to needle them a little bit about it. And then number two, Pulp Fiction I just like more than Saving Private Ryan, though I love Saving Private Ryan. So my hobby horse. Anything else?
I'll be brief because we're out of time, but especially for a lot of the kind of articles that come up in Journal Club, if you've got weird methodological questions, a lot of times supplemental materials can help out. And a lot of times people don't look there, so that can be a big help when you're writing your presentation.
Thoughts on Pulp Fiction though?
I mean, it is an excellent movie, but in the canon, Jackie Brown is the better film.
I dig Jackie Brown. I don't agree, but I dig it. So, Visual Romance is my favorite thing he's written. So, okay, yeah. All right, we're out over time. We're 4 minutes over time. Any other final thoughts? Any questions about Journal Club?